Okay, let's start with our common inflammations, which are really, some of them are non-specific. We really don't know. Most of them are related to allergens, but sometimes we never really know what causes some of the inflammations that we see. Some of them that we do know are eczema, contact dermatitis, atopic dermatitis. Things that we want to look at are avoidance therapy, steroid therapy. Avoidance therapy, of course, is avoiding whatever causes you to break out, and steroid therapy is using your corticosteroids. You never want to stop corticosteroids abruptly. It can cause adrenal suppression, immune suppression, and peptic ulcers. So you want to be careful with treating your patients with steroids. We use them pretty often for inflammation. You always want to assess any patient who's on steroids, regardless of why they're on them, for an increased temperature because their immune system is suppressed, rash, WBCs, need to check their blood pressure, signs and symptoms of infection, decreased healing, and especially epigastric pain. You may be seeing with the steroid use some esophageal rupture, so you want to be sure that someone complains about gastric pain and they're on steroids, to be very aware of that. Steroids also delays healing. Some of the things that we can give for severe itching, other than Benadryl we usually give for mild to moderate itching. Be sure that you teach your patients not to use alcohol with antihistamines. But one of the drugs that is very popular for severe itching is Atarax, hydroxine. So, hydroxyzine, it's not hydroxine, hydroxyzine. So, they want to be very careful when you take Atarax as well, because it causes you to be severely drowsy. So you want to be sure that you're watching that. Contact dermatitis can be anything from poison ivy to sumac, and of course, if we are using a steroid or antihistamine cream, if you put a warm, moist dressing over it for short periods when you first put it on, it'll help the medication uh, dissolve into the wound. Eczema is atopic type of dermatitis. It's usually chronic, has severe itching. Be sure that, it's pretty common with children. And a lot of children that have eczema, hardly anybody wants to touch them or play with them or anything because they're afraid they're going to contract eczema from them. Eczema is not contagious. It's more of a familial thing. So, parents definitely need to be playing with their child and their regardless, to be sure to help them develop uh, in their stages of development. We do have some life-threatening inflammation that wasn't mentioned by your book this year, but has been before, and I know we've seen this in the hospital, is the necrotizing fasciitis. It's very difficult to recognize. It spreads really rapidly. Those of you that have seen it, it can become quite fatal very quickly. So early diagnosis and antibiotics and surgical debridement is how we're going to treat that. So Stevens-Johnson syndrome can fall under this category. It can be life-threatening. It's a severe reaction to medication, usually an antibiotic. And your patient may develop flu-like symptoms, but most of all, he's just really red all over, and it can actually cause them to have some upper respiratory and mucosal erosions, which may actually cause the patient to need to be put on the ventilator or to have dialysis because of renal involvement. Usually, removal of the medication that caused them to develop Stevens-Johnson syndrome is basically all we should have to do. But if it's severe, they may even have to go to the burn center to be treated for the damage that was done to their skin. And then we have toxic epidermal necrolysis, which is known as 10. It's part of the same type of syndrome. If you get rid of the medication, you should be able to stop the process. Oh, I forgot to put our beginning from our slide here. How awful. Oh well. It's been a while since I've done this. Y'all have to forgive me. So we got a patient who is taking a topical steroid for treatment. What instruction are we going to give them? Well, I just told you that A was a good thing to do, so you should have remembered that one. Let's go to the next one. Healthcare provider recommended Benadryl to treat the patient's hives. What does the RN suggest to the patient for self-care? Yep, we just talked about avoid alcohol consumption. And we know that cool environments and cool showers are better for itching. We know that using an emollient cream is not going to help reduce the itching. And you shouldn't just put a topical antibiotic cream on after bathing in the evening. What you want is something that's going to take care of the itch. In order to assist a healthcare provider in determining if avoidance therapy is appropriate, what should you ask? Well, I don't know what a history of surgery for removal of skin growth has to do with avoidance therapy. I don't know what a change in the appearance of a mole has to do with avoidance therapy. I don't know why someone who has a similar skin problem would be avoidance therapy. I do believe that if you've used any new soaps, detergents, or personal care items, you're trying to find out what the patient should avoid. So, this is what psoriasis looks like. This is what psoriatic nails look like. So people with psoriasis will actually get nails that look like this. Be sure you remember what these look like. So let's talk about psoriasis. It's a lifelong disorder. There is no cure for it. We can control the exacerbations and the itching and the scaling to some degree. But patients who have this have a really low self-esteem and body image. So it's very debilitating to them. It's hard for them to get out and be social, even to work, depending on how bad their psoriasis is. It's actually a scaling disorder that's caused by the proliferation of the epidermal cells. Most skin sheds every 28 days, and in psoriasis, it's every 4 to 5 days. So they think it's probably an autoimmune disorder, and of course, it's very strongly genetic. It will improve in warmer climates and sun exposure. You may get psoriatic arthritis as well with psoriasis. So some of the things we can do for psoriasis. I keep forgetting to turn my pages, guys. Okay. Some of our interventions, topical therapies. Again, the corticosteroids with the warm, moist dressings. Tar preparations used to be used a lot. They're usually used in the hospital setting. They stink and they stain your skin. You have to leave it on for 2 hours. Ultraviolet light will cause cellular destruction. Patients need to be taught to wear sunglasses. This is a lot like being under the bilirubin light and you put shades over the baby's eyes. So be sure to teach your patient to wear sunglasses when they are doing ultraviolet light therapy. We also do some systemic treatment with biological agents such as methotrexate, Enbrel. These are things that can cause renal, liver, and bone suppression. None of these biological drugs should be given to anyone who might be pregnant or may be getting pregnant. People who are using these need to make, especially the women especially, need to make sure that they are using very good birth control because these do cause a lot of problems with pregnancy. Calcipotriene, Calcipotriene, is a topical cream that they use quite often. And again, you have to watch to make sure that you teach them to avoid pregnancy. So if you have a 58-year-old that will start on Enbrel, what do you want to teach them? Well, what does Enbrel do? Enbrel will suppress. It's like a chemotherapy drug. It does suppression. So with a 58-year-old woman, you would want her to report signs and symptoms of infection. Had that been a 28-year-old, even using 2 methods of contraceptives is really not good enough. They really should not be taking it at all if they are able to get pregnant. So what does the treatment for psoriasis include? Well, we mentioned all of those except Cipro. And Cipro is an antibiotic, so that's not going to help you with psoriasis. You have a female patient that's been prescribed acitretin or Soratane for psoriasis. Definitely want to teach a female patient, out of all of those things, that strict birth control measures are necessary because it is a systemic drug. The glasses are for ultraviolet light. It's not the first choice in treating psoriasis. In fact, Enbrel has become the #1 choice now, and methotrexate is in close second with that. So what do you need to know about benign tumors? They are benign. Warts are a benign tumor. We remove those by cryosurgery. Be sure you know that. Skin abrasion. Dermabrasion for facial skin disorders. You want to make sure your patient isn't on aspirin before the procedure. Be sure you know that. And keloids are an overgrowth of scar tissue, which we seldom see, but they do happen. So you need to know that. This young lady had her ear pierced, and she developed this keloid from her ear piercing. The thing about having a keloid is if you have it removed, what's going to happen? It's scar tissue. It's going to grow back. So keloids are really hard for patients to adjust to because of the body image. So what's this and how do you treat it? It's a wart, and we treat it with cryosurgery. Okay, let's talk about skin cancer now. We all know that overexposure to sun is the major cause. We should all know that. So let's talk about the 3 different types of skin cancer that we normally see. We normally see squamous cell, basal cell, and melanoma. Squamous cells are usually a red ceiling lesion that doesn't heal. So scaling. I can't read my own writing. Isn't that awful? It's a red scaling lesion. I was wondering how it would seal. And it doesn't heal. And it can be anywhere on your body. It's in the usually originates in the epidermis. It's potentially metastatic, and you'll usually see it around the ear, the lip, or maybe external genitalia. I had a friend that had one come up on her nose. So that's real close enough to an ear and a lip. Your basal cell carcinoma, or of course from your basal cell layer, they often go unnoticed, but they rarely metastasize. So if you're going to get one of these, the basal cell is probably the best one to get. Melanoma you want to run as far as you can run from. It arises from the melon-producing epidermal cells. It is highly metastatic, and survival is going to depend on early detection and treatment. And usually what you're going to see with melanoma is maybe a mole that was brown or black that's maybe have some red in it or some white in it or some blue in it or all three colors in it and have some sudden itching in it. So you want to make sure that you know those. So the best thing is to prevent melanoma or squamous or basal cell cancer. So avoid sunlight. And I don't know how many nurses know that you should avoid tanning beds that still use tanning beds, and then they wonder why they get skin cancer. Secondary prevention, which is more of a screening than it is anything secondary should be a screening. So it's early detection, sort of like doing your breast exams. It is a screening, and you want to inspect the body areas, known moles, and any changes, and map out any of them. You can have a partner. Actually, you know, I can't see my back too well, so if you have anything on your back and you're married or have a partner, then it's pretty cool to have one of them look at that for you. Kovner's phenomenon is when you have a severely injured skin, a burn, or any type of skin that can actually develop into cancer. So how are we going to intervene with this? Surgical management, of course. And of course chemotherapy, radiation, excision. We can do all these things for our prevention. So what statement made by the patient with a skin lesion indicates a need for further teaching? My wife helps me keep track of all my... That's a good thing, right? And that said the need for further teaching. I cover the spot with a small bandage so my belt doesn't rub it. That's a good thing. I know this spot is not melanoma because it is red, not black. That is not a good thing. And that means that he needs further education there. So let's talk a little bit about acne. Even though your book doesn't really go into that much about acne. Acne is a big problem for teenagers. It's a very progressive disorders of comedones that are comedones that are black and have black heads and white heads. They're usually on your face and the upper trunk. Scarring can usually be very extensive. Accutane is one of the drugs of choice to treat acne, but you want to make sure that they are not pregnant, don't plan on getting pregnant, and are unable to get pregnant if they're taking Accutane. Be sure they're on a good birth control method. Tetracycline is something that they give, and they give it, they have to take it every day for like a year. You have to teach your patient to stay out of the sun, especially in the hot part of the day, and not to drink milk with medication because milk interferes with the absorption of tetracycline. So, what is that? We just talked about acne. Sure, that's exactly what it is. Oh, and also something that you can't do with acne is that, or with Accutane, you have to avoid the use of vitamin A because vitamin A actually causes some issues with the absorption of vitamin A, and Accutane do not get along. And it can also cause you to be intolerant of eye contacts. So you might not be able to wear your contacts if you're taking Accutane. You have to wear your glasses. All right. Now to the big one. Care of patients with burns. This is a biggie. This has a lot of information in it, so I'm going to carry on for the next 15 minutes, and then we'll probably stop there and start again with another one, which will probably be tomorrow. Okay. The main thing to know, it doesn't matter how big the burn is, whether it's a little burn or a big burn. It's going to cause inflammation and fluid loss. And because of the way that burns causes all this inflammation and fluid losses, it's going to influence and change the function of all your body systems. Care is very complicated in a burn victim, and you have to have very comprehensive nursing care. We see fluid and protein losses, we see sepsis, and then we see all these body system changes, the metabolic, endocrine, respiratory, cardiac, hematological, and immune functions. When you damage your skin, all these things happen from damaged skin and loss of fluids, which is because of damaged skin. We need to be sure that we are aware of special considerations, such as burns over joints, because they can cause contractures. Your nose and your ears, if they're burnt, they have very little blood supply, so they are very at high risk not to heal. And we want to make sure that we splint joints to try to preserve mobility. Most of your patients want to be in a position of comfort, which is usually the joints are flexed, and you want to splint the joints where they're not flexed so that they do not contracture. One thing to know about burns is that the number one thing you do when you come upon a burn victim is you're going to assess the airway, is your number one thing to do. But once you've assessed the airway, done your ABCs, you need to stop the burning process. And the way you stop the burning process is you cool your patient off with cool water in increments. You want to be careful not to cause hypothermia, especially in children, but you can run cool water on your patient for 10-15 minutes, stop, and then when they start having pain again, start it again, because if we can get that burning process stopped, then we can have less tissue damage. And it's very important for us to know that. So what about sepsis? Do y'all remember the signs and symptoms of sepsis? Increased heart rate, decreased blood pressure, decreased output, increased respirations, and increase in temperature. These are things you need to watch for in sepsis. So anatomical changes and functional changes in our skin. These are some, skin's our largest organ, and when it gets damaged, we lose a lot. So we lose our skin integrity. Again, the skin will regenerate itself as long as part of your dermis survives. If it gets to the point where all your dermis is destroyed, it's not going to be able to repair itself. When we have anatomical changes, we have an increased chance of infection. And some of the functional changes that we're going to see when the skin is burned is we're going to see fluid and electrolyte imbalances. We're going to lose fluid loss through evaporation. We're going to see a loss of vitamin D because we can't process it without the skin. Inability to regulate body temperatures. So those are some things that skin changes with burns can affect. Then we have our depths of burns. These are the classification of burns. They're also categorized as minor, moderate, and major. The superficial thickness is like your sunburn. Your partial thickness is going to include up to a third of your dermis. And then you have your superficial partial thickness, which includes most of your dermis. Your deep partial thickness is to the bone. Full thickness is the bones included, and the deep full thickness is even worse. So I don't expect you to know all these categorizing, but you do need to know that the superficial thickness is like a sunburn and how you would treat that. Partial thickness is going to have blisters, and it may require dressing changes. So we're going to go through and mention some more things. Page 466 is going to sum up your characteristics for you. Your minor, such as sunburn, is, where are you? Looking for my remote for my fan. There we go. The minor is like superficial thickness. It's such as the sunburn, formerly known as first degree burn. usually have some mild edema. There is a lot of pain there because you've got your nerve endings. You're going to have an increased heat sensitivity. You don't want to be, if you get into a warm shower with your sunburn, any of those of you that's been burnt knows how awful that feels. How do we treat the minor ones? Well, cool moist towel to stop that burning process, and then topical sprays is all we have to do. It will heal itself within 3 days. May have some peeling of the skin that was damaged, the top layer. Then we have the moderate, which is partial thickness, which used to be known as the 2nd degree burn. This one has blisters. You may need dressing changes. If we're going to do a dressing change, you'll need to know how to do a dressing change, but you need to know the steps you need to take in order to get ready to do that dressing change. Number one is be sure that you have pain medication on board before you start the process. If it's a PO pain pill, you need to give it at least an hour ahead of time. If it's an IV, you can give it 15 minutes ahead of time. You want to give the pain medicine. You want to be sure to debride any dead tissue or anything else. You can snip it out with scissors, whatever you need to do. If you're going to culture the wound, now would be the time to culture the wound after you get all the dead tissue debrided out and cleaned out. Then after you get your culture to make sure nothing's growing in the wound, you're going to apply your Silvadene or what other medications that's been ordered, and then you're going to replace the dressing. And you need to do them in that order. So be sure you know that order. Then the major ones are the 3rd and the 4th degree. So just remember too that when you have multiple dressings, such if you had a person that had 4 deep partial thickness burns on their leg, that you would do one dressing, get it completely done, and then clean everything up and start all over with the second one. You do not go from one to the other one. Each one has to be treated separately. You'll cross-contaminate or auto-contaminate. Auto-contamination is when you get the bacteria from one of the wounds to the other one. Cross-contamination has to do with if you bring in something. So what I want you to remember is that you do not want to use the same gloves to do all 4 dressing changes on one leg. You do one dressing change, then start all over for your second one. Wash your hands, put on your gloves. Do not touch them in any way, form, or fashion from the other one. Okay? Oh, vascular changes. This is a big one. This is where we start getting complicated. Remember I told you the content gets a little complicated? Oh, this is where it gets complicated. When you have a burn of 20% or greater, it requires fluid resuscitation. And the reason it requires fluid resuscitation is because you have fluid shifts and then you have fluid remobilization. The first initial 12 to 36 hours, and when I say these hours, don't get pinned to these hours because it all depends on the condition of your patient as to how soon these phases go. Some can be longer than others, some can be shorter. It's what happens in that phase that makes it that phase. So in your first 12 to 24 hours, we consider that the initial phase, phase 1. And what usually happens with your burn is you have vasoconstriction, right? You have the inflammatory response that does vasoconstriction initially, and then the vessels dilate to bring the macrophages and things to the injured site, which causes capillary permeability. It's also known as capillary leak syndrome. Once that occurs, you're going to start seeing vascular fluids. Now, the vascular fluids are the fluids that are in your veins and your arteries, capillaries. You're going to start seeing that fluid move from your vessels to the interstitial spaces, which is called third spacing. Because the fluid goes out of the vascular space, the circulating fluid, it leads to decreased blood volume. And because you have a decreased blood volume, you have a decreased blood pressure. So you're looking at hypovolemia, right? Decreased blood volume and decreased blood pressure. You will also develop metabolic acidosis because of the increased metabolism that you're having and the shift of the fluids. Because when the fluids shift, when the vascular fluid goes into the interstitial spaces, hyperkalemia develops because of two reasons. The red blood cells are getting destroyed from the burn, and so therefore the particles that make up the red blood cell, which includes potassium, get shifted out of the cell and into the plasma. You also have your potassium sodium pump, and what's happening is the more potassium that comes out into the vascular spaces, the more sodium is going to go into the interstitial spaces. So basically you're going to have hyperkalemia occurring, and then you're going to have hyponatremia because salt is going to follow water. So wherever your fluid goes, your salt is going to go with it. And then the potassium is out in the vascular spaces kicking out the sodium. So what do you think we would see with hematocrit and our hemoglobin? Well, because we have decreased vascular fluid, we are going to see an increase in the hematocrit and the hemoglobin. It's not necessarily a good thing. As we have an increase in this hemoglobin, it may look like we have good oxygenation when we don't, because it's not able, what it's going to do is it's going to cause your blood to be thickened, and it's not going to be able to move very well through your system. So that is your fluid shift. When you start seeing fluid remobilization, this occurs 24 to 48 hours after you do your initial fluid resuscitation during that fluid shift. So during this period of fluid remobilization, we're going to see that the cell integrity is restored, the capillaries become less permeable, and we see diuresing beginning. We see, in the fluid shifts, we're going to see no urine output. In the fluid remobilization, we're going to see the diuresing occur. And then, of course, with the remobilization, we're going to see a change in our electrolytes again. We're going to still see hyponatremia because we have these wounds that are continually leaking fluids out. And our kidneys have now started diuresing and working. So now all of the sodium that we were trying to, that was being stored, is now being excreted out. So now we're having hyponatremia, still having hyponatremia. But our calcium is going to move back into the cells, and it's also being excreted through the kidneys. So then we're going to see hypokalemia instead of hyperkalemia. So these are the things that happen between the fluid shift and the fluid remobilization. This is just the vascular changes. This has nothing to do with well, it has everything to do with, but these are just vascular changes that occur. So let's shift on over to the cardiac changes, pulmonary changes, and such. Now I can kind of cut these down pretty close for you. With our cardiac changes, what we're going to see is an increased heart rate, of course, because our body's trying to compensate. And then we're going to have decreased cardiac output simply because we have decreased blood pressure and our blood vessels have thickened blood in them. So we have decreased cardiac output. Our pulmonary changes, we're going to have decreased lung functions related to either hot air that's been inhaled, flames that may have been inhaled, smoke inhalation. One of the major causes of death in resuscitation phase is an impaired airway. So we really want to, in that resuscitative phase, do our ABCs and then do our fluid resuscitation. Pulmonary can also be affected by burns that circle around, circumferential burns around the chest. If we have eschar that's circling around the chest and keeping the chest from expanding, that can also decrease our respiratory efforts. So we have to watch out for those sort of things. With our GI, we are having a decreased perfusion to the gut, because what happens when we go into hypovolemic shock? We have everything, the oxygen and things always go to the brain, the heart, the kidneys, functions. So our GI is going to suffer. We're not going to give them any blood supply. We're going to see ileuses develop and possibly Curling's ulcers that are going to form from the gastric secretions that are forming. So with these particular patients, when we have a burn that's over 20-25%, we know we're going to do fluid resuscitation. We should drop an NG tube down these people. Metabolic changes that we're going to have. Remember, I've been talking about the nitrogen balance. Well, of course, we're going to have a negative nitrogen balance because we have catabolism going on, where the body's breaking down its own proteins to help try to keep the body in homeostasis. It's greatly increased. We need oxygen needs are high, related to, of course, the core temperature of the body being increased, the metabolism, and of course we'll have an increase in glucose because of the damage that's done initially. Of course, eventually it's going to change because we're going to use it all up, but initially this is what we see happen. With the metabolic, we would like to see them have 5,000 calories or more with these patients to try to support the metabolic changes. How do we get those calories down them if they can't eat? Usually we start enteral feedings as soon as possible, as soon as we get them stabilized, so we can try to prevent the curling ulcers and ileuses. And as soon as they're able to eat, we try to get them to eat. Of course, our immune system is going to be high risk for infection because we have no barrier to keep the infections out. And what we're going to see with this that shows signs of sepsis is going to be your decreased blood pressure, and of course a temperature greater than 102. Those are things that are going to tell us that we have sepsis. And I'm going to stop here and then start with compensatory responses later.